It is my pleasure to introduce tonight's speaker, Dr. Paulo Soares. Dr. Soares is a globally recognized orthodontist specializing in myofunctional and airway orthodontics, dental sleep medicine, and multidisciplinary care. He is an accomplished educator and international lecturer and has trained more than 800 healthcare providers worldwide. He is passionate about advancing patient care through innovation, collaboration, and a patient-centered approach. Dr. Soares, thank you for being here with us tonight. The floor is yours.
Thank you very much, Alison. So this is a great joy for me to be here speaking about the Froggymouth, which is a product that I simply love. I actually have like I would say like a funny relationship with the Froggymouth because honestly, I must say the first time I saw it, not knowing what it was all about, but just by the looks of it, when I saw it, I honestly thought, oh my God, this is so stupid. Why would you use something like this? I couldn't understand why you would use something to keep your lips open, because most of the time we're trying to get those lips to be closed, try to teach those patients to breathe through the nose. And I didn't have like the best initial impression just by judging it, just by looking into it and seeing it. But I got curious and I went to see what it was all about, and I'm very glad that I did it. And I became a fan. I became a fan, a user myself, and like a provider. I do use this on the treatments I carry on with great success, and that's what we'll be discussing tonight. Is what's the concept? Basically, why should we be interested in something like this in a broader sense into the connection between myofunctional therapy and orthodontics. Uh, what's the concept behind the frog mouth? It's solid. It has very good science backing it up. And then I will show some clinical applications where I believe this is very useful. So, um, I'm Brazilian. I'm an orthodontist from Brazil, worked in Brazil for 22 years before moving to Canada. And I've been here for the last 4 years with my family. And for very early on in my career, I was searching for answers that I didn't have on my formal training, most related to why am I seeing relapse in all my cases, why I did everything by the book, why I achieved good results on many cases, why patients have fixed retainers and they eventually come back in months post-treatment showing some signs of relapse. That bothered me a lot. Honestly, I was trained to blame the patient. It's always the patient's fault. It's because they are not using their retainers properly, or they're doing something that they were not following our instructions. But many of them had fixed retainers, like bonded directly to the teeth, and even then they were showing rotations and things moving. And I simply didn't. At that time, I didn't have like proper answers for this, and that problem, that very specific problem, put me into this like long search for answers on how things happen. And then I started realizing something that it still, honestly, it still saddens me a little bit about our whole profession, about orthodontics in general, and this is worldwide, which is there is very little thought into put into the causes of the problems we treat every day. Speaking of um, prevalence, this is only getting worse. The amount of kids presenting with malocclusion from very early ages has only risen throughout the last decades, up to a moment where maybe eight kids out of 10 will present some form of malocclusion very early on life, which is it's another word to say that kids are not growing the way they were meant to be. And this is not, again, this is not improving. Every medical science strives for fighting, cure, or prevention. We do not do this in orthodontics. We just keep advancing the technology. We have 300 different ways to move a tooth, but we should be thinking more about why. Why is the problem that I'm seeing present to begin with? What problem, what situation led to the manifestation of these disorders? Am I just like repeating myself? Am I doing something later? I'm just alleviating symptoms, or am I treating the cause? So almost every kid that steps into our practice presents any type of malocclusion. We owe to these kids, and we owe to the newer generations a better understanding and a better solution into what this is happening and what can be done to provide them a better pathway, a better growth and development throughout their lives. We cannot get to these kids and just like wait until they are in permanent dentition to put them on braces, on aligners, and mechanically create a makeup. It's a band-aid solution, and whenever we use like mechanics to correct a smile. We are not treating the cause of the issue. We are like it's a compensation basically. I'm not against this at all. I'm an orthodontist. I do everything you can possibly imagine in orthodontics. I'm just saying that it would be even better if we didn't even need to do some of the procedures that we actually do. So trying to find out that type of relationship, what might be like behind this huge number of malocclusion worldwide. One of our colleagues, Dr. Derek Mahoney from Australia, he did a very, very interesting study published recently where he did a retrospective study in many of his previously treated patients. These were all patients requiring orthodontic intervention for this study specifically between the age 7 and 9. And he found out that amongst those patients that required orthodontic treatment, 92% of them had sleep disordered breathing as well. This is huge. Not only the number is high, but the implications of it, the importance of this huge association between sleep disordered breathing and malocclusion. So this is a way to see that most patients presenting malocclusion, they also present sleep disordered breathing issues. Uh, there are many reasons why this is important, such as all the physiological manifestations and implications that not being able to breathe and not being able to sleep properly will cause into anyone's life, especially in a growing patient. But if we go to extreme, for example, I have never seen anyone, I have never read any death certificate attesting that an individual died because they have an overjet or an underbite or a class 2 malocclusion or crowding or anything. This is like a minor problem health-wise, but sleep apnea kills. Sleep apnea is a life-threatening condition and might lead to like severe problems. And knowing that the early signs of those diseases are connected with malocclusion, and anytime we do our clinical evaluation in our patients, we can be in a position to screen for those problems and not necessarily diagnosing them, but seeing how things start, we need to pay attention. So this is not just my like opinion. We have again science behind this. This is a paper that I loved, published by a team from Seoul, including Dr. Audrey Yoon, our very dear Dr. Audrey Yoon, that does, she has like a major contributions in our current knowledge between this relationship on the way that we breathe impacting the way that we develop and how to deal with this, like from an early stage. And on this specific paper, they conclude saying that early diagnosis and intervention are critical in managing pediatric sleep disordered breathing. Dentists, through screening and early treatment, can significantly influence craniofacial growth and health outcomes. A multidisciplinary approach is essential for effective management and improving the quality of life and long-term health of affected children. Uh, we know that we have like a mixed group here. We have orthodontists, we have general practitioners, we have pediatric dentists, but it doesn't matter like where yours, which is your angle on it. We are all in this to improve the health of our kids. and knowing that these situations are deeply connected with malocclusion, which is something that we very easily can diagnose in our practice, we have this moral obligation to know better and understand how these connections go so we can properly screen and early treatment. It's not just noticing the problem, it's providing effective and early treatment so these problems will not become more complex as those kids age. Uh, this is still part of that same paper. They are showing how the manifestation of the obstructive sleep apnea, which is the end stage, which is the most severe form of sleep disordered breathing, is a combination of anatomical and non-anatomical factors. So not everything that contributes to the development of pediatric OSA is under our scope of practice, but we do see the signs of it, we see the red flags, and even if you're not treating that specific issue, we need to know about it so we can properly refer. But the craniofacial structure, which is our area of work, our scope of practice, we need to understand how it's connected to the OSA. There is a multitude of interrelationship between these conditions, and we cannot stop on just dealing with some of these issues. For example, abnormal orofacial growth. I believe most of us here would be comfortable or familiar with the concept of palatal expansion, of growth guidance appliances, of diagnosing and understanding abnormal growth and noticing when an arch is in need to be developed better on. But if we just do this, if we mechanically, let's say we have constricted maxillary arch and let's expand this arch, is this helpful? It absolutely is helpful, but if you just mechanically expand the arch, it will not necessarily break the cycle, because if we do not get the tongue to correct its position, if we do not get this patient to stop breathing through the mouth, this will lead to the recurrence of this cycle, and the patient will go back into relapse and will never get them out of this situation. So understanding this relationship is very important, goes a long way of knowing that we cannot work alone in this field and knowing which is our position on what is our contribution to solving this problem in a broader way. So a quick review on what is expected in terms of normal growth. Uh, our face from babyhood to adulthood, it's supposed to grow in this forward and downwards direction. If our face grows like this, we are getting enough space on our nasal airways. We are getting the maxilla, the mandible growing away from the oropharynx and creating enough space for the airflow. We have space in the arch to house permanent dentition. There must be space in the arch to accommodate the tongue. The problem, though, is that this type of normal growth is becoming more and more rare, as we just saw in the first slide. But more importantly, this is not a given. This is only going to happen in anyone's lives if it's properly guided. Guided based on ideal function. It's the function creating the form. If we are able to maintain nasal breathing, correct tongue position in the roof of the mouth, proper lip seal, proper swallowing movements, all the combination of these muscle actions will guide the growth into this normal direction. So growing from these small size primary dentition into mixed dentition, finally into permanent dentition, can only happen normally if it's sustained by balanced function. As an example, if our patient is a mouth breather, we'll have severe limitations and severe alteration in how this process is taking place. If a kid is breathing through the mouth, the first thing that happens when we breathe through the mouth is that our tongue changed its position. So we cannot hold the tongue in the roof of the mouth anymore because we need to keep the mouth open so we are able to breathe. So if something goes wrong into our nasal airways, we get congestion, we get any blockage, anything impeding anyone's ability to breathe through the nose, and then we resort to mouth breathing as a compensation, we will open our lips and keep them open for a prolonged time. Our tongue will descend, and this will change dramatically the direction of growth in the face. Instead of growing forward and downwards, the face assumes this significant more vertical component. We get this clockwise rotation, and then we have limitation. We have limitation, deficiency on the growth of the maxilla. We have mandible deficiency as well. And all of these reduced or altered skeletal structures, they will also influence the soft tissue structures that should be functioning inside of them. The function will influence the form, will guide how the anatomy is developing. But if we have underdeveloped anatomy, if we have constricted arches, if our mandible is retruded, if our maxilla is retruded, these will cause severe adaptations in the soft tissues as well, because they will need to live inside these more restrained structures, altering the function as well. The function creates the form, but the form influences the function. So this relationship is uh, impossible to disconnect. And this will play a major role in creating and maintaining malocclusions. If you want to dig a little bit deeper into this relationship, into how oral dysfunction will ultimately lead to development of malocclusions, I emphatically suggest you to read this review by Linda Donofrio, which is a speech pathologist from the US. She compiled this review showing which type of disorder, which type of soft tissue dysfunction will lead to anatomical adaptation, on how basically on how different types of malocclusions form. And on the conclusions, she wrote that malocclusion and the acquired craniofacial dysmorphology are the result of chronic oral dysfunction and oral myofunctional disorders. So it's the soft tissue dysfunction leading to a craniofacial dysmorphology. We might need to do mechanics, we might need to use expanders, to use braces, to use aligners, to use all the tools we know and we are familiar with. But if we do not treat these oral dysfunctions, we will not achieve stability. Long-term stability is critical to understand the underlying pathologies contributing to the malocclusion, open bite, and hard palate collapse. Oh, that's interesting. So we everywhere we go on social media, and it seems to be like the hot topic of the moment. Everybody's talking about airways and the muscles, and it's like taking over orthodontics all over. Is this like the new trends, the new thing happening? Not at all. This is not a new concept at all. This is Edward Engel, the father of orthodontics, over 100 years ago, saying, "We are just beginning to realize how common and varied the vicious habits of the lips and tongue are, how powerful and persistent they are in causing and maintaining malocclusion. There is no hope in the success of treatment unless these habits are corrected." Like since the beginning. So the first one of us, like modern orthodontics, this was a very clear concept from him back in the day. So how come we are now like rediscovering this all of a sudden? What I must say is that we are now in the best position we ever were, because now we have tools, we have ways to be effective on overcoming these problems. I can hear in my mind one of my professors from my ortho program, my dear Professor Ravelli. He also he keep always mentioning throughout our clinic, saying, "Be aware of the tongue, pay attention to the tongue." So I can still to this day hear in my mind him saying this, but That's all we would know. And but we didn't have like effective ways to treat it. We would use difficult orthopedic appliances that were very hard to construct, even harder to be used. So translating this to the modern practice, the fast-paced lives we are all living today, it, it's not like a good ways to provide orthodontic treatment anymore. So we were indeed lacking good solutions to overcome these problems that are known since ever. So in summary, every malocclusion has a cause, and the cause is a combination between breathing and myofunctional problem. Most of the time, it starts with a breathing disorders causing myofunctional adaptations. If you can't breathe through your nose properly, you will adapt. You will find a way to keep breathing. But once those breathing functions are treated, when they are treated, many times they are not even treated. But let's say even if the original problem is treated, the postural habit persists. In other words, let's say you have a patient, you see that they have breathing issues, you send this patient to an ENT and they get treated either through medication or they might have surgery and remove tonsils and adenoids. Even then, the myofunctional problem will persist because of how the patient is adapted to it. If we do not train and teach our patients to breathe through the nose, restore the tongue position, and restore the natural growth direction, these will be, it's as if the surgery was not even done. So the patients will maintain their habits to breathe through the mouth, even when they can't breathe through the nose. So we have a major part to play here. So my invitation tonight is, irrespective of the case you are presented with, start your case by thinking what's going on here, what caused the malocclusion in this particular patient. So every time we look at them, take one step back. So don't be too eager to look inside their mouths. Take a step back, look at them into their entirety, and try to understand what led them to that position. What's happening throughout their whole development, that at that moment when you're facing your patient, this is the condition you're looking at. They didn't wake up this morning showing whatever situation they're showing. What they have is been on the making since they were born. uh, we might still need to do everything we know what to do. We will expand them, we will guide the minimal growth, we will align the teeth when needed, we'll do every type of mechanics we need to do. But if we do not answer the question, what caused the problem to begin with, that same problem will come back to haunt us, will come back to harm them more importantly. They will not be able to maintain the balance moving forward, especially as now we are more aware of the need to do, I don't even like this name early intervention, because it for me, like, emotionally, I feel like we are doing something before it was meant to be, like ahead of time. It's not early intervention, it's timely intervention. It's doing the treatment when it's needed, when it's warranted. It's not going ahead of doing unnecessary interventions. Quite the opposite. They are begging for help. If we go beyond looking into the teeth and understand what's causing the problem and what other relationship those same causes are producing as well, we will understand about the urgency of those treatments. But we cannot stop at just mechanically improving whatever condition we see. We need to restore proper function. So how can we know what caused this problem? We need to see them moving. We need to see them acting in real life. We need to see how they breathe. We need to see how they swallow. Do they keep the lips together at rest? Do they use additional muscles? Are they recruiting additional muscles to just keep the lips together? How they swallow, how they move every single oral and facial muscle. Those muscles are shaping their faces as they grow. And again, even if we correct the malocclusion, if those muscles are not balanced, if those functions are not established, they'll have problems all over again. So for example, let's see just this first example here. An open bite with an obvious culprit. We can see the tongue poking out. And at that stage, it doesn't matter if she was a thumb sucker, if she had a pacifier, if she was not breastfed and use a bottle. What matters is that she has an anterior tongue thrust in a wrong swallowing movement, an atypical swallowing movement. She has a low tongue resting position. And these will perpetuate the problem. Let's say we go there and we use elastics or wires and we do whatever mechanics you think of closing that open bite. Is there any orthodontic appliance that is stronger than the muscles of the tongue? There is not. The tongue is able to exert up to 500 grams when doing this movement of the typical swallowing of poking forward the way we're seeing right here. There is no elastics, there's no wire, there's nothing we do that will be stronger and more consistent than the tongue. So you might be even able to correct, but that correction will just be there for a brief time because the muscles will always win. We need to establish proper muscle balance as we go through our treatment. If we get those patients early enough, you might do the whole treatment just based on reparting the muscle function. Most of the time, it's too late for this, meaning most of the times when we get the chance to see the patient, it's not prevention anymore. They already show a problem that needs correction. So most of the times we need to do something. That something could be, again, expansion is the most prevalent procedure we will be doing. Many times it involves alignment. Many times it involves everything, again, every technique, every procedure we know of. But on every single case, there is a cause. There is a dysfunction present, and we need to pay attention and treat those dysfunction as well. So, some examples. When assessing a patient, let's try to go beyond our conventional classification. This is let's say this is an edge-to-edge abide with crowding on both arches, narrow arches, a class 2, division 2, an anterior open bite, an anterior cross bite. So let's go beyond this and let's understand the contribution of mouth breathing, a typical reverse swallowing, tongue thrust, low tongue posture, how these dysfunctions uh, literally produce the malocclusion we are seeing. The good thing about understanding this relationship is that when you remove that causation effect, when you treat the muscles, when you establish proper breathing, and you help the patient learn in a different way to move the muscles, those cases will change dramatically. So those examples were just done by using myofunctional appliances, restoring proper breathing and myofunctional balance, leading to much better uh, growth, much better outcome for this patient. As you can see here, especially in these first two examples, the top ones, they were older when they started treatment in like late mixed dentition. And then you can see that those results of that timing here, they are not corrected, they are not fully done. This is just how proper balance looks like. This is not meant to be a replacement for aligners, a replacement for braces, a replacement for orthodontics, in other words. This is not a replacement for orthodontics. In other words, treating the muscles is not the same thing as treating the teeth and the bone. It's just adding another layer to our work, which is let's deal with the bone these morphologies. Let's treat with the malocclusion. Let's treat all the manifestation, but let's also pay attention to function and restore proper function. When we do so, we at least create a much more stable situation. Which situation here, which patient would you like in your chair to start your orthodontic treatment? Would you rather bond brackets in this mouth right here, or would you rather get this patient to come to this moment so you can finish this case much easier with much better stability? If we have the chance to start early enough, these patients might go a long way, and in many situations, we might not even need a further treatment later in life because we were able to get them while young, where a good amount of facial natural growth was still present, and we were able to redirect that growth to the normal position, and they will be able to reach like its full potential of growth. In many cases, avoiding a need for orthodontics in the permanent dentition. This is never like up to us to promise anything. Most of these treatments are based on compliance. Even if it were not the case, we can never promise how the patient will develop throughout the years. And we are not treating them to, that's not like a goal for the treatment. The goal for the treatment is not avoid braces. The goal for the treatment is establishing health right now, assisting you achieving a proper natural growth or the best potential for your growth. The good side effect of it is that some of these patients might indeed like avoid the need for further treatment, but even if they do, that later treatment should be much simpler and achieving much better stability. Because at the end of the day, this is what we need to create. We need the balance between how size and function, basically. We need our teeth and our arch to accommodate the muscles properly, but we need the muscles to maintain the anatomy we developed. We can only create stability if that stability comes from proper nasal breathing and proper muscle function. Not a new concept at all. So, on every single case, enhancing function will lead to a better outcome. We might need, in many cases, to use many different techniques, but the ultimate goal is restoring proper function. Uh, this is another paper that I highly recommend you not reading, like thoroughly studying it, because I believe this is a guide, like a guide to what we should be doing. So this is a roadmap of craniofacial growth modification for children with lip disorder breathing that we already know that they are our patients. Most of our patients presenting or complaining of malocclusion, they present some level of sleep disordered breathing. Keep in mind that mouth breathing is sleep disordered breathing. You don't need to have sleep apnea to have a sleep problem if you simply breathe through your mouth. This is a form, a milder form, but it's sleep disorder breathing right there. Uh, so what the authors aim to do in this paper here is creating, as they said, a roadmap on showcasing what the literature has proven to be effective on different age ranges. What type of intervention has been proved efficient as the patient develops, so we can do proper intervention whenever we diagnose a problem. So they came out with the table here. Let me make this a little bit bigger, showing which type of interventions might be needed if we're treating patients in primary dentition, in mixed dentition, late mixed, or permanent dentition, basically. So as an example, for example, if we have a patient presenting problems in the nasomaxillary complex, in other words, narrow maxilla or underdeveloped maxilla, so we might need to do slow or semi-rapid expansion. We might need to do mid-facial advancement. By the way, this is a protractive face mask, a protraction face mask that can accomplish anterior posterior growth. If we're dealing with an older patient, we might need to have bone anchored appliances to achieve proper rates of skeletal development for this patient. So there are many different recommendations for treatment in different ages, but there is one constant here, one thing that is needed from birth to adulthood, which is myofunctional therapy. No matter what intervention you do, that intervention was needed because the patient had a myofunctional problem. So you might need to do expansion, you might even need to use TEDs, you might need to do advancement of the maxilla, advancement of the mandible. You might need to send this patient for a denotonsillectomy. But what you know you will need to do is establishing nasal breathing, proper tongue posture, proper chewing, swallowing, and addressing all the power functions. So paying attention to how the muscles work is required in every age, on every patient. Uh, it's an easy way out of the problem saying that, okay, yes, I'm aware of this and I'm referring those patients to myofunctional therapy. I even have a myofunctional therapist working with me, and I commend you on that. That's the best thing that's the right thing to do. We need to be closer. We need to be working together with myofunctional therapists. We can't be choosing which patient we are referring. But obviously, I understand there are many obstacles on that relationship. On referring patients out, there are costs involved on it. There is always the compliance issue. Many families will not be able to afford doing two treatments at once. Some might say that, okay, let me finish the orthodontics and then I go see the myofunctional therapist. There are many things in the way, like practical problems that might prevent the patient, might prevent us from establishing this ideal relationship. That's where I believe the Froggymouth is particularly useful. This is also not meant to be a replacement for myofunctional therapy. The same way any myofunctional appliance will never replace orthodontics, no myofunctional appliance will also replace a myofunctional therapist. It's an assistance, it's a tool that will make our work more effective. It's actually a bridge. This is something that will get us together, will get our side to be more developed, will allow us to be more aware of the problem, to provide a better treatment for our patients, and to have better conversations, better integration with allied healthcare providers as well. So, as a rule for our treatment goals, these are some points we should be looking to achieve on every single case we try to treat. We need to establish nasal breathing, correct tongue resting position, establish lip seal while resting, correct swallowing, proper facial development. These will naturally lead to a balanced occlusion into proper teeth alignment. So these is like our the gospel. These are the rules I go by every day. This is what I try to establish on every single patient because these are the keys to success. So, okay, fine. So, what about the frog mouth finally? Where does it come into place? As I said initially, when I first saw it, I said, okay, there's something wrong here. How come I'm using an appliance that has these goals on improving function, prevent our patients to being able to close the lips? Because I had in my mind initially that this was an appliance to be worn throughout long periods. So if you keep this on your mouth for long periods, if you even like say you go to sleep with that appliance, this can't be right because you need your lips to be closed so you can breathe through your nose. But then obviously this was just my first impression when I saw it, and this is definitely not the case. So the froggy mouth is meant to be used just for 15 minutes per day. I will go back to the full protocol. So this is a passive appliance meant to literally rewire our brain on correcting the swallowing function. The swallowing function is like a pillar of myofunctional balance because in order to have a proper swallowing, you need to first be able to breathe through your nose and be able to rest your tongue in the roof of the mouth. So anyone who's able to swallow properly, we already know that this person is breathing properly and is resting their tongue on the right spot. Because swallowing is the culmination, is the most important function in this like myofunctional universe because it's a combination of everything else. Only someone who's able to breathe through the nose, rest the tongue properly, keeping the lips together at rest, is able to swallow. So whenever we treat the swallow, we are inherently treating all these other dysfunctions in combination. So that's why this very simple appliance is able to correct lingual posture, rehabilitating swallowing, help restoring nasal breathing. This is again, this will never reduce the size of adenoids in someone who needs adenotonsillectomy. But once you establish that your patient is able to breathe through the nose, that's when this will do the training. So this is training. It supports orofacial growth in children, and it will contribute to stabilizing, obtaining results, avoiding relapse of mechanical treatment in adults as well. So an adult is a grown-up kid that didn't have the chance to have these problems corrected while they were young, which means their habits are even more ingrained. So treating myofunctional disorders in adults is not only needed, but I'll say even more needed than in kids because it's harder to do. So we do need to use this in adult patients as well. So you only need to treat the muscles in those patients you want to create stability. On those patients that you want relapse to happen, you don't need to worry about. It's as simple as that. How the appliance works. So this is the magic that obviously it's not magic, but when I saw it, oh my God, this is so genius. By the way, it was created by Dr. Patrick Fallows in France, and he has extraordinary experience in myofunctional therapy in orthodontics, in pediatric orthodontics. He's a book author, a researcher, and he noticed the need for that type of solution, and he had the genius to create this appliance, which is again very effective. And I'm running a little because I want to get to the case to show you some examples. Uh, Size. Deciding the size of appliance is quite easy. Basically, if you are below uh, 12, 13, you should be choosing the size small. Medium would be for girls or even women. Large mostly for men because you always want to keep a little bit of freeway space between the corners of the appliance and the corners of the mouth. We need to let these 2 millimeter borders on either side. So whenever in doubt, go smaller. So the small appliance will most of the cases be more effective. So you're only using large appliance if you're an adult, and if you're like a bigger person, if you're a smaller person, and especially if you're a child, you will choose the small one, the medium. So let me show you this example, which is one of the most striking. This is an old, not mine patient. You will find this video and many others on the Froggymouth YouTube channel. So just go on YouTube, searching for Froggymouth. You'll find the channel over there, and you find this video and many others there. Uh, One thing that drew me to the froggy mouth was that myofunctional therapy and myofunctional orthodontics was nothing new to me when I started with the froggy mouth. I have been using different type of myofunctional appliance for almost 18 years when I first discovered the froggy mouth. With I'll say mixed results in many patients, extraordinary, unbelievable results. But I was struggling with many others based on compliance. Compliance was always a problem because most occlusion guide or growth guidance appliances require about an hour of daily usage plus sleep. So they are active appliances, help shaping dental arches, help training a better tongue position, blocking out the space to establish or help establish nasal breathing. They do lots of good things, but one thing that they don't do well is the passive training for the tongue because it's so easy to keep those appliances inside. It's easy to have any nighttime appliance in your mouth, any myofunctional guide in your mouth, and not necessarily using this properly. You can have an appliance in your mouth and sleeping through the night with your lips open, the appliance just like loose inside, not guiding the tongue to the right position, not doing anything other than just being there, not promoting proper re-education. So I had patients who were like lingering through treatment. They were wearing those appliances for months and months and months, in sometimes with very poor results. And then you lose the compliance, you lose patients' motivation, and you need to come up with different strategies. The beauty of the froggy mouth is that you don't need to teach your patients to do anything because what it will do is it prevents lip seal. So when you use your frog mouth, let me put mine here. So let me see if I can speak with it. By the way, you cannot speak using it. I'm just trying to demonstrate. When you have your frog mouth in place, you can't that you can't close your lips. So even if you try, you are unable to keep your lips closed. Once that happens, once you break the lip seal, uh, over time, your patient will eventually need to swallow. We swallow around 2,000, between 2,000 and 2,500 times a day, uh, mostly because of saliva. We accumulate saliva in the mouth, we are constantly swallowing. So if you just hold this appliance in place for a few minutes, you'll be swallowing many, many, many times. A typical swallowing involves an anterior tongue thrust, so the tongue pokes forward, and to compensate, to avoid drooling or avoid spitting when swallowing, will overuse, will recruit perioral muscles such as the buccinatus, the mentalis muscle, to overclose the lips with great strength to prevent the tongue from moving out. So it starts with the tongue in the wrong position, moving to the wrong place, and then we compensate by overusing the perioral muscles. All of a sudden, you play some Froggymouth, and then you can't use your facial muscles anymore because you can't close them. So you are forced to find an alternative. You're forced to train your tongue to behave differently so it can collect the saliva, initiate the peristaltic movement by resting and moving this in coordination. So that's the clever design about the froggy mouth, which is it's pretty simple. It's just breaking the lip seal, but doing so, it forces the tongue to learn how to behave, how to do the correct movement. Uh, and once you do it, it gets we rewire the brain controlling that function, and we never forget. So it's repeating the way that this function works. It's literally training the patients to swallow properly. And remember, the swallowing properly means that the tongue resting position is correct, and then we are able to breathe through the nose because we can keep the lips sealed. So although throughout those 15 minutes we are indeed keeping the lips open, we are not breathing through the mouth because the appliance forces your tongue to move up, creating the seal in the back. So because the tongue is up, you're not breathing through the mouth, although your lips are open. So we establish better tongue position, we improve swallowing, and as a side effect, we improve or we reinforce nasal breathing. So look at this video. This is a 3-year-old patient with cerebral palsy. It's a very young patient presenting a very severe condition that prevents him from learning as typical patients would. So providing him with instructions would not do the work. You cannot get this child and just direct them on doing something else. It must be automatic. So this is the kid, the first moment he got the frog mouth, and later on the video, you will see him in the 2-week follow-up. Just 2 weeks in a patient with cerebral palsy. Look at that. So initially, you see very clear signs of struggle. He's trying very, very hard to close his lips. He's forcing the mentalis, forcing the buccinator, the orbicularis oris. He's trying to overcome the plies, but he can't. And you keep the patient using this for, again, just 15 minutes daily. So then he comes back 2 weeks later. And 2 weeks later, look at this on how relaxed the patient is. Did you see his tongue moving up? So he's swallowing. He's swallowing by using the tongue the right way. There is no movement whatsoever on the face. That is just calm and quiet. And again, this is a 3-year-old boy with cerebral palsy, which is a very extreme indication on how effective on the learning aspect this appliance is. Because even when you have these learning disabilities, the appliance will deeply rewire your brain to establish a better position. How is this related to orthodontics? So imagine growing up, imagine trying to grow your face and having this extraordinary pressure on your face. All the muscles on the outside are hyperactive, contributing to restriction, growth restriction. The result of it will be narrow arches, underdeveloped jaws, and crowding, like severe crowding. If we get a patient to transitioning from that situation to this situation in just 2 weeks, this is like is it sounds like a miracle. It's very, very, very impressive. Again, this is not meant to be replacing any myofunctional therapy. This is just another tool that we all use in our arsenal, in our toolbox to get those outcomes achieved. Balance between breathing, muscle, and growth. So clinical applications. Oh, before I show this, let me show just this last one. By the way, all these videos and descriptions of the material, you probably be receiving, the team will connect with you through email later, and we'll send you some of the resources that you can use to further learn about the device. There is a right way to do it, and the right way is we need to keep the head straight. We need to maintain proper eye level 90 degrees. So the best way to do is use the Froggymouth while you are watching TV, or if you don't want to watch TV, any type of screen, but pay attention to the position because we need to keep the neck straight, the proper eye gaze, so we allow the patient to learn without drooling, without the gravity being a problem. So patients must be sitting down, hold the head upright for 15 minutes for this to work, and consistency is the key. So some applications. Uh, Primary dentition, do you see what I mean about not being a prevention? So you can be very young and already present some problems that require immediate intervention. So this is a 3-year-old, not even three, she was actually 2 and 8 months with a crossbite. So this is an obvious indication for a palatal expansion because let's say, oh, let's improve the function. How so? How can you use an appliance that builds upon the premise that you're able to rest your tongue in the roof of the mouth? If the tongue is unable to move up to the roof of the mouth, it's unable to work. So let's go ahead and do the expansion and create the space. But once you do the space, look at how you can see the saliva flowing through in between. So that's the moment where we issue the Froggymouth, because it will not only maintain that space, because the best retainer ever in the world is a tongue in its right position. So let's expand. Beautiful. You need to do it. In some cases, this is one of them. But she's just a 3-year-old with huge amount of growth ahead of her, and we need to direct that growth in the right position based on correcting the muscles. And that's where the frog mouth comes into picture to address tongue position and swallowing function now that she's able to breathe through the mouth. So would be wrong or simply not effective using a frog mouth here? Yes, it would. So you would not be using a frog mouth in a patient who can't fit the tongue on the palate, either because it's too narrow, or let's say a patient with a tongue tie. A patient with a tongue tie needs to be released. The tongue needs to be able to move to the roof of the mouth so it can work properly. So these are all situations we need to address before issuing, before starting with the frog mouth. So some other examples. So what is this class 3 here indicating? This is indicating a very low tongue resting posture. The tongue is so low that it's not helping pushing the maxilla moving forward, and it's allowing the mandible to run freely. So we need to interfere. We need to open, like we need to do some build-ups. We need to open the bite, so we need to allow the maxilla to move forward. But doing so, we need the tongue to be the maintainer. We need the tongue to either correct, help while correcting, but we also need the tongue to keep pushing forward as we progress. Another way that we can incorporate frog mouth is even if we're doing treatment for older patients, this is late mixed dentition that we are already using aligners. We need to address mandible posture. We need to address tongue posture. We need to address arch. We have lots of things to do, and we will do all of them. So we chose to combine aligners with the frog mouth in that patient right here. So we did what like a typical aligner plane would be, improving arch shape, correcting the spaces, all looking great, all going well. But then we get to a position where we establish the mandible position, we establish proper like a mandible alignment, I would say, But look at this. We have a posterior open bite. We have some teeth that are still erupting, but we see the tongue right there. Uh, there are no elastics, no intercuspation elastics, no aligners, no leveling arch, nothing that will overcome the power of the tongue. So then we issue a frog mouth in that stage to assist while treating. So for some patients, this would be the beginning of the treatment. In some other situations, it's something that we use throughout the treatment. In many situations, this is part of our retention protocol. If you're dealing with older patients or ongoing, let's say you have many ongoing patients that now you are aware of what needs to be done in terms to establish tongue posture, proper swallowing, and you didn't have a chance to do this earlier into treatment, we can incorporate this on any type of the treatment, or any in timing of the treatment. What you need to do is what the patient needs to present is they need to be able to breathe through the nose. They need to be able to move the tongue up high. So let's say you are doing active palatal expansion. The patient has a fixed expander. Not the right time to do Froggymouth because the patient simply cannot correct. You cannot teach the patient to move the tongue up because the tongue cannot go there. So we would wait until the expander is removed to issue a frog mouth. So we issue, and then a couple of months later, we see the occlusion setting up, and look at how natural and balanced the face is once we incorporate the muscle training into orthodontic treatment as well. In many cases, we have an opportunity to go much further with the myofunctional correction. So this is a patient we are treating that up to this moment, he only had a nighttime appliance combined with the froggy mouth, which is how we train them, how we treat those functions to be corrected. So froggy mouth can be in specific situations a standalone appliance, or in most cases, at least in my experience, it's great as a tool that you add to many different types of treatments to do what it does best: establish tongue resting position, proper swallowing, guiding the subsequent growth in a much more natural way. So this is a 15-year-old patient that was able to overcome this deep bite, this retruded mandible, this misaligned arch, occlusal cant, everything you can see here, just by combining a myofunctional nighttime appliance and a froggy mouth. Because these are not the appliances causing the correction, it's actually his muscles working in the way they were meant to do, guiding, orienting his growth moving forward. We also incorporate frog mouth in treatments for TMJ dysfunctions. TMJ dysfunction also share the same cause of malocclusion for a given patient. The result of the muscle imbalance will translate to be teeth in awkward position. In some other patients, they simply don't care about how the teeth are positioned, but they feel pain. They have joint pain, they have clicking, they clench, they have many other type of functional disorders that we will understand or we will classify as temporomandibular disorders as well, which again share the same myofunctional causes, and they also need the myofunctional correction to maintain proper stability. So this is a 4-month follow-up in a patient that had no orthodontic complaint. Not that she didn't need, she had lots of need for orthodontics, but it was not a problem that caused the family to seek treatment at this moment. But her joint problems and her like overall case of craniofacial pain led her into treatment. And then we combined again the combination of a myofunctional appliance, a nighttime appliance with the froggy mouth to restore function in just 4 months. In a 13-year-old, look at how different the face is. Look at how different the lips are configured. We establish more relaxation on the perioral muscles, and we allow the arch to develop by the power of the tongue and the proper swallowing. So it goes a long way in both being a correcting device or something that you use to actively assist on the correction. In many other cases, is maintenance, is creating the balance you need for long-term stability into the treatment. So I know that I needed to rush through today because we had a lot to cover. I hope it was like enough at least to like pique your attention to see how useful, that is in many different scenarios on your practice. And I hope we can like connect to like move forward with the education, move forward the training, so become more and more comfortable to issue the Froggymouth. Reach out to the team. They will be sending you more resources on the appliance, on how, again, more details into size selection and the specific protocol. Keep in mind there's, again, 15 minutes daily, head on the proper like eye level. We need to be sitting down, looking forward straight, avoiding awkward head position, and no talking. If the patient throughout those 15 minutes, if they take it out to speak, that the clock will be reset. They need to go back to zero and wear it for another 50 minutes. So it's 50 minutes uninterrupted that will assist us establishing those goals. If you care, and I believe you should, is there any science behind it? Is there any published science behind the frog mouth? I'm very happy to report that there is. There are some good articles on it, some prospective studies on the frog mouth. Just go on the PubMed, search for frog mouth as a keyword, and you'll find many articles there as well. If you want to connect, you can either scan this QR code or just go on Instagram, Dr. Paulo Soares. You will find me there. Send me a message and I'll be more than happy to connect, to share more of my experience and some like tips on how to implement the frog mouth on your practice.